Good day, everyone, and I hope you had a wonderful day so far and are ready to listen to what we will talk about, which is recurrent miscarriages tonight. And I'm very happy to have another doctor from IVF-Life group. Dr. Izquierdo, Manuel Izquierdo, is with us tonight. Hello, Dr. Izquierdo. How are you feeling tonight? Thank you so much for joining. This is your first webinar with my IVF fences, so I'm glad that you were able to join us, and of course, you will present this very interesting topic for us. How was your day going?
I'm good, and I'm very happy to share our knowledge with you tonight about a very interesting topic about recurrent miscarriage that maybe most patients are dealing with and are trying to get answers to their questions. I'm happy and thank you for this opportunity.
Thank you so much indeed. And let me just briefly tell you that as always, we will simply start with Dr. Izquierdo's presentation on this particular topic. And afterwards, you will be able to simply ask your questions. So if there's anything that you would like to ask, if there are some comments you would like to share with us as well, go ahead, type those in the chat section. And after the presentation, Dr. Izquierdo definitely will be happy to help you out how much is possible, of course. Let me just briefly tell you that, as you probably know, my IVF Fences is a part of European Fertility Society, and we are simply here to educate you, to give you some answers, but also to support you. There are so many webinars we've discussed, so many topics we've discussed, and we are happy to be able to help you out in any way we can. So thanks everyone for joining. We are definitely for you here, so don't hesitate. Ask anything you wish to ask. And Dr. Izquierdo, I think we can go ahead with the presentation. Are we ready?
Yes, thank you.
Thank you.
So, good evening to all. And today, as we were telling, we are going to have an insight about patients experiencing recurrent miscarriages or recurring pregnancy losses. So this is a very interesting topic. Maybe the first question is to define what kind of pregnancy losses we are telling of. Sometimes we are facing biochemical pregnancy. Biochemical pregnancy means some kind of miscarriage, very early miscarriage, because we are able to detect pregnancy hormonal levels, but we will never confirm by ultrasound scan. Early miscarriage is defined as a pregnancy that is lost before 12 weeks. Late miscarriages are defined as miscarriages occurring after week number 12. Premature delivery means another question, and it is related with delivery before the week 37 of pregnancy. So it's very easy to understand that depending on the kind of pregnancy loss we are facing, the studies, the medical approach maybe will be very different in terms of what studies to be performed and what kind of intervention. So, as we were mentioning, recurrent miscarriages or repeated pregnancy losses are miscarriages that occur before the week number 20. And it's about 20-25 of all the pregnancies in terms of the whole patients being pregnant. But recurrent miscarriage is not so frequent. It affects about 1% of the women, and the classical definition is being more than 2 miscarriages in a row for women over 35 years old, or women under 35 years old having fertility problems. And we usually consider 3 consecutive miscarriages in women under 35 years old, not having, at least not knowing that they have a fertility problem. So, what causes we are finding in pregnancy losses? Most of them are caused by genetics. The most frequent one is the chromosome number alteration in the embryo. So most of the miscarriages are related with chromosomal alteration in terms of number of chromosomes. The good chromosome number is called euploidy, and the bad chromosome number is called aneuploidy. So most of the embryos having a bad chromosome number or aneuploidy will not implant, but many of them that will implant will end in a miscarriage. This alteration in the number of chromosomes can occur by an error in the formation of the egg, or sometimes in the sperm, and sometimes, few times, are related with problems in the chromosome composition in the parents, in the progenitors. Less frequent, we can find immunological alterations, coagulation issues. We call these thrombophilia factors. Is an ongoing debate about infections during the first 3 months of pregnancy and its relation with the miscarriages. Endometrial receptivity, most of them related with non-implanting embryos or biochemical miscarriage. And other health risk factors like obesity, or associated pathologies like polycystic ovaries. There are some doubts about this condition. Most of the time that we find miscarriage in these women are more related with the glucose metabolism than the polycystic ovaries by itself. Another conditions like non-treated or not well-treated diabetes, questions like multiple pregnancy, because a problem in a space, there is a limited space in the uterus for containing more than one pregnancy, and sometimes it is a factor for having miscarriage, as well as some others like cervical incompetence, that the cervix is a little bit open than expected, more open than expected, and it contributes to miscarriage. And don't forget about all the questions related with lifestyle, like no smoking, no drinking, having no overweight, etc., that are the main condition for having a healthy life, but as well for having a healthy pregnancy. And there are many publications about specialized units for this high-risk pregnancy coming from repeated miscarriage, and the emotional factor involved in contributing for a pregnancy to go as better as possible. So, as we were saying, the chromosome factor is maybe the most important thing. So, it's mandatory to have a karyotype coming from the patients. Karyotype means the blood chromosome, a study of the chromosomes in the cells of the blood, and is mandatory to have this test done for the parents. PGTA means the chromosomal analysis of the embryos. Thrombophilia testing is a blood test searching for coagulation conditions. We will tell later about all of these questions. Very important, very important. A very detailed study of the uterus is not so clear. The most mentioned uterine abnormality related with miscarriage was septate uterus, but some papers show some randomized clinical trials are telling that the factors affecting uterine abnormalities are not always involved in this. But my thinking is that once we know about a septate uterus or a fibroid in the cavity, we need, or our advice for the patients is, maybe this factor is contributing to the miscarriages or the implantation of the embryo, and it's a good option to consider correcting these abnormalities. The most important tool for assessing about the uterine conditions today maybe is 3D ultrasound scan, but we many times complete this ultrasound scan through hysterosalpingography or hysteroscopy by seeing with a small camera the uterine cavity, having a very detailed view of the cavity. And complementary tests we are telling later as well, as endometrial receptivity mapping or immunological map, are sometimes indicated and are useful tools for us. So how can we tell if an embryo has a good chromosomal composition? We offer the patients, maybe they will have a clear benefit in these cases, selecting the embryos that get in day 5, we call these embryos blastocysts, with a small biopsy coming from the outer cells and taking some of these cells with a very, very small biopsy, we can have the chromosomal analysis of these cells and make the idea that most of the times this karyotype coming from these external cells maybe will be the same as the whole embryo. So there are a lot of publications telling that this maybe will contribute to decrease the time to pregnancy and increase the chances of having an ongoing pregnancy. For having these embryos, it's known that we need to go to an ovarian stimulation, because as you can see later, if we have more than one embryo, we increase the probabilities of having, after this study, one good embryo to transfer. So it's good to have more than one embryo, and we are going to have an ovarian stimulation, an egg retrieval, an in vitro fertilization, and waiting 5 days in the laboratory for these embryos to become blastocyst stage, and then performing the biopsy. After this biopsy, we will freeze these embryos and waiting for the result. And once we have the result, we will plan to transfer this. And how we do perform this chromosomal analysis? Today, the technology has a great impact, and we have a very useful tool called next generation sequencing. That means by informatic tools, we can have a picture like these ones. The median line means 2 chromosomes for every number of chromosome. This is the good one, euploid embryos. And we have an upper line and a bottom line. The upper line means an excess of chromosomes. This is a trisomy of chromosome number 13 because we have an increase to this upper line from the basal line. Okay, and monosomy, or having only one chromosome, will be detected if the peak will be down this median line. Okay, so there is a lot of research telling about the chromosomal composition of these embryos, and today we can tell that most likely these embryos will be euploid, and most likely these embryos will be aneuploid. So, and what is our expectancy of having euploid embryos in terms of the age of the women? So the main factor is women's age, and we know our statistics is telling that under 35 years old, 62% of the embryos, 62 percent of blastocyst stage embryos implant. And over 40 years old, we see a decrease in implantation rate, and we are about 18% of implantation. So what happens if we perform in women, older women, PGTA? That we see that we are having at least the same implantation rate, and sometimes even a little bit higher implantation rate, because we are discarding all the embryos that have no good chromosomal composition and will not implant. So PGTA in these older women means that we are compensating, balancing the effect, the most important effect of the age of the woman. So let's see in a clear way that sometimes we have no good embryos to transfer. Sometimes we have a low number of eggs because not only with older age we have more chromosomal abnormalities, but we have more probabilities of having a low ovarian reserve. It means that we maybe are not having a good number of embryos for being studied. As you can see, this very, very illustrative picture, this blue line means the aneuploid, the no good chromosome number embryos in terms of age of the woman in blastocyst stage embryos. So as you can see, over 36, 37 years old, there is an increase in aneuploidies, no good chromosome number embryos, and you can fix this data. 44 years old women are having 90% of the embryos with aneuploidies. So this means we need a lot of embryos for having the chance of detecting the euploid ones. And as you can see, this green line is increasing at the same time of aneuploid rate. And this green line, as you can see, is miscarriage rate. So aneuploid embryos that will implant. Most of them will not implant, as I was telling you previously, but the implanted ones will have a lot of chances of having a miscarriage, because the aneuploids is the most frequent question related with the miscarriage. Okay, so an alternative in this case is not having a good number of embryos, or having a lot of embryos not having the good chromosome number constitution, will be considering egg donation as an alternative. Most of the time not needing PGTA if we are going to egg donation, because the aneuploid rate in women under 35 years old in Spain is mandatory to be under 35 years old for donating eggs. It's not mandatory to perform. It's not necessary to consider all the time genetic testing. We have 30% of aneuploid rate in these cases, but is considered a number that is not in the same range that increasing age is showing clearly a benefit of performing PGTA for selecting the higher probability of the embryo to implant and ongoing pregnancy rate, ongoing pregnancy. So egg donation as an option means that, as in Spain, it's mandatory to have a very detailed study for being accepted in the egg donation program. We have a lot of candidates that are passing through this intensive testing in terms of genetic studies, psychological evaluation, etc. And we need to match the patient's phenotype. We need to have similar physical characteristics like the patient to match the donor with the patient. And we offer extra matching. In Spain, it's mandatory to study 5 genetic conditions, very frequent, and discarding these donors if they have this condition. But we offer expanded genetic matching, performing extra studies if patients want to go with this extra genetic testing. What about egg donation and embryo transfer? We usually perform a trial cycle. This means we prefer offering the patients the possibility of preparing the uterus in advance, not for going to have the embryo transfer, the embryo placement in the uterus, but for knowing the response of the body of the women, the endometrium, to the hormonal preparation. This means we are going to prepare with the standard protocol, and we are performing ultrasound scan and hormonal testing for assuring the endometrium is in a good condition for having a lot of opportunities of embryo implantation. Sometimes we detect that this endometrial preparation is not so good, and we have alternatives, changing the protocol, the medication, the dose, complementary supplementation of hormones, etc. And then once we confirm the endometrium is in a good condition for implanting, in terms of very good lining of the endometrium, very good measurement, and good hormonal levels, we propose the real cycle for embryo transfer. Our experience, and it's very important for patients to know that the cumulative pregnancy rate in egg donation is the highest pregnancy rate in all the fertility treatments. So after the first embryo transfer, we have implantation in 70% of the patients. And the second embryo transfer, cumulative pregnancy rate, this means adding the first trial implantation plus the second trial implantation rate, is 91%. And after 3 embryo transfers, adding the first one, the second one, and the third one, we get more than 95% of the patients implanted. So these questions are very important to be noticed, because sometimes patients are worrying about not succeeding after the first embryo transfer, even going to egg donation. But in these questions, sometimes it's very important to know that you are still keeping in your second and third embryo transfer a very good implantation rate. And after these three trials, the 3 to 5% of the patients not being pregnant will be the real patients having repeated implantation failure. Sometimes patients are worrying about if they have repeated implantation failure, and we always tell that by definition, we need to know that very good embryos have not implanted at least in 2 or 3 times. So the real data about patients having problems not related with embryos are very, very limited. As I am telling you, about 3 to 5% maybe of the patients. So what about endometrial receptivity? The very, very important. We consider implantation is a conversation between the embryo and the endometrium. It's very difficult research field because there is no good animal model for studying, and the research is very, very slow. But we are having more information every year. We know that the receptivity, the endometrial receptivity, is related with the progesterone exposition. So once we have a good endometrium and we start with progesterone supplementation, we have the same days of progesterone most of the times as the embryo is. So 5 days of progesterone for day 5 embryos, and so on. This is the general rule, but not for all the patients. We know right now that patients being diagnosed as repeated implantation failure patients, maybe some of them will have a narrower window of implantation or displaced, moved window of implantation. We are thinking the general rule will work for these women, and we have the surprise that after performing these receptivity testings, we discover the endometrium is sometimes pre-receptive and sometimes post-receptive. What does it mean? This information will help us in these cases to set the best moment for placing the embryo in the endometrium. And if the window of implantation is moved and is post-receptive, we need to have the embryo implantation sometimes some hours before as expected, or even 1 day compared with the regular rule or the usual rule. And the other way around with the pre-receptive. This means the endometrium is not good enough at this point and we need to wait extra time. So these tests are useful because they will tell if the window of implantation is in a good point or we need to move this window of implantation. Very less frequent questions related with immunological issues. We were telling in the beginning about thrombophilia factors. Thrombophilia factors are problems with the coagulation, not with the regular coagulation we ask to be studied when we are going to the operating room for a regular surgery. But these are related with the blood clots in the very, very small vessels that will interfere in the communication, in the circulation between the placenta and the endometrium. And we have some factors. Antiphospholipid syndrome are antibodies affecting this coagulation condition, and is where we are asking to perform tests like cardiolipin, lupic anticoagulant, and some others. And is when we are going to advise the patient to have sometimes the treatment with low dose aspirin or heparin. There is a lot of research about immunology cells like natural killer cells, T helper lymphocytes, about histocompatibility antigen and the relation with KIR receptors in the woman, etc. But today is a very, very starting field in terms of research. So when we perform this immunological testing, etc., when we have discarded the most common questions related with genetics, thrombophilia factors, etc. Let's have some examples about real cases we had in our group related with problems getting pregnant or having or telling the benefit of the study of the embryos. This first case study is a 42 years old woman having 2 miscarriages and performing 2 previous insemination cycles and in vitro fertilization cycles with a very low ovarian reserve in terms of anti-Mullerian hormone and antral follicle count. These women having in vitro fertilization with genetic testing, PGTA, of 2 day 5 embryos, it was detected that these 2 embryos were aneuploid embryos. Aneuploid embryos means no embryos to transfer. We had a Down syndrome embryo, 47 chromosomes. It has an extra 21 chromosome, and this one was having a 13 chromosome extra. So this patient went to an egg donation because the low ovarian reserve, low number of embryos, and the 2 embryos were no good embryos, no euploid embryos. The recommendation was considering egg donation. And in the first single embryo transfer, she succeeded having a positive beta HCG and a healthy child. A second case study, this is a younger woman having a good ovarian reserve, a good antral follicle count, and having previous IVF cycles with transferring day 3 embryos. In this case, we are not telling about miscarriage, but it's only to show you the advantage of considering the genetic testing in these cases. So having a lot of eggs, a lot of embryos, because she has a very good ovarian reserve, sometimes you have an advantage, not for the age, because the aneuploid rate is low compared with 42, 44 years old women, but you decrease the probabilities of transferring embryos that they are not going to implant. The first embryo transfer of single embryo transfer coming from 6 euploid embryos after the study of 8 blastocyst stage embryos was negative. But when we perform the endometrial receptivity mapping, we detected that, thinking that 5 days later the progesterone exposition will be receptive, it was early and is needed to wait extra days, and this endometrial receptivity test told us that the best day was 2 days later. The endometrium is in a good receptivity condition 2 days later, compared with the regular rule of 5 days. So this is our group picture. We are having clinics in UK, Germany, and Spain, and it's been a pleasure sharing this information with you, and I'm open to trying to answer all your questions from now on.
Thank you so much, Dr. Izquierdo, for a very interesting presentation, for explaining all the causes, but also for providing those cases. I think that many times all our patients are interested in, especially on the cases that you already had, right? And you know what was working. And now it is time for your questions. I don't have any questions yet, but I'm sure you will be happy to ask something. So this is your time. Don't hesitate. We are just here for you. So if you wish to ask anything on our topic, go ahead, type this in, and I'm sure Dr. Izquierdo will be able to help you out a bit. So go ahead and let's give it a second. I'm sure that we will have some questions in a minute or so. So just bear with us, of course. And in the meantime, perhaps, Dr. Izquierdo, if you can tell us how is it when it comes to recurrent miscarriages? I know that this is something that is very, difficult to overcome. And if you are able to tell me, provide us with some statistics, how often does this really happen?
Yeah, we were telling that it's not so frequent. And I want all the people to know that 65% of patients having recurrent pregnancy losses is expected to have a healthy child in the next pregnancy. So 2/3 with no intervention are having a healthy child. So we set the number of 2 or 3 miscarriages for speaking about recurrent miscarriage, but it's very difficult to transmit to the patients that sometimes it happens only by chance, that you have bad luck in your first 2 pregnancies and there's no problem to study, but we need to study the basic things for discarding the most common problems, just in case we are facing a very real recurrent pregnancy loss case, and we need to have an intervention. And the most important, for me, is very curious that most of the times patients are thinking that the problem is related with the woman. I'm rejecting the embryo. Maybe I moved a lot and the embryo dropped. I did something wrong, and I always tell the patients most of the times it's related with the embryo. It's important to know that we most of the cases is the embryo who is failing, and we are able to study the most important thing in the embryo, and sometimes only performing this we succeed in the next pregnancy. So two key messages from my side. The first one, not performing anything, 2/3 of the patients, 2 out of 3 of the patients will succeed in the next pregnancy. Miscarriage is so frequent in the human race. And the second message is most of the times it's related with the embryo. And we know that is the chromosomal composition, the main factor. And we can study this. We don't forget about all the other questions, but maybe we need to transmit the patients these key messages for their peace of mind.
Yeah, exactly. Thank you so much, of course, for this reminder, because I think that this is very often, it's just so stressful that people tend to forget that, of course, there are some main things that we can still work on, and we can still. I remember just one of the doctors simply said that, when you get pregnant, this is a good sign already, even though, of course, there is a miscarriage, but there's a good sign already, and we can now work on getting the healthy baby, of course. Okay. Yeah. Thank you so much indeed. And in the meantime, we did receive, of course, a few questions, so let me go straight to those. This is the first question. Sorry, just give me a second. I don't see it. Yeah, here it is. Is a pregnancy with a young woman's donor egg the same as donor's pregnancy? Does the age of the donor count for the success of the pregnancy?
Here in Spain, and I think in most of the countries allowing egg donation, the age is limited to under 35 years old. And the reason is very clear. If you remember my previous graphics, the pregnancy chances are mostly the same in the range between 18, 20 years old and 35 years old. And it does depend in the age of the donor. When we transfer these embryos to a woman being 40 years old, 44 years old, we keep the pregnancy chances of the woman who donated the eggs. So we cannot tell any great difference between the age of the donor. This is a very recurrent question in the office. Oh, doctor, we will prefer the donor as young as possible. Don't worry, we have similar pregnancy rates, and all the groups have similar pregnancy rates, and the graphics coming from the United States I was showing you in the presentation tells quite similar results. No difference, significant difference between the age of the donor. Okay.
Brilliant. Thank you so much for your first question and for the reassurance here, for sure. And let's have a look. Victoria has another question. I have had 5 transfers, 3 failed implantation, followed by 2 miscarriages. Last miscarriage was genetic tested and was normal. Clinic wants to just try again with another transfer, not PGTA tested. Should I just try again or do further testings?
Very difficult question to answer. Maybe if you transfer this embryo, a new embryo, you could succeed, and not all the miscarriages are related with genetics. Maybe in this case, I will go to this endometrial receptivity testing or maybe immunological question. It's very difficult because we don't know about if some extra testing were performed. When we tell about a miscarriage, implantation, and endometrial receptivity is not sometimes related because implantation occurs. The thing is that the pregnancy is not going on most of the times. So my recommendation will be performing uterine assessment, ultrasound scan, hysteroscopy, maybe immunological questions. But we are telling in a field of research, and remember that sometimes transferring a new embryo genetically tested, sometimes it succeeds, and sometimes we have no clear answer about what is going on.
Mm-hmm. Okay, so yeah, hope that was, of course, helpful for you. Thank you so much for that advice here. And any thoughts on endometriosis as a potential reason for recurrent losses of PGT-tested euploids?
Very good question. Very good question. Our knowledge is that endometriosis is affecting most of the times the ovarian response when you are in an ovarian stimulation, and sometimes maybe the quality of the eggs. But is very important to note that we have the same pregnancy rates in egg donation model when we transfer to a woman having endometriosis. So endometriosis, we have the idea that is not related with embryo implantation. Sometimes for the patients it's very confusing because endometriosis comes from the name endometrium, and they are thinking, I have an inflammation of the endometrium because I have endometriosis. Endometriosis is having endometrial tissue out of the place of the uterus. And it doesn't mean you have a problem in your endometrium and your uterus and with the implantation. The only thing, and I don't want to have a deeper debate right now, is adenomyosis. Adenomyosis means an endometriosis inside the muscular tissue in the wall of the uterus. This could impact endometrial receptivity, and because they are very near the endometrium, and then could provide a disbalance of the regulators of the receptivity, and maybe adenomyosis is related with embryo implantation, but I cannot tell that having an endometrioma assist with endometriosis in your ovaries is related with decreased endometrial receptivity and endometrial embryo implantation, because the model with egg donation transferring to women suffering endometriosis gives the same pregnancy implantation rate compared with women not having endometriosis.
All right. Marina, thank you so much again for that question and for your help with that. And let me have a look, possibly our final question for today. So if you have more, you know what to do. Go ahead, type those in the chat. And here's the question from Benson. My question is for a person with a first miscarriage without knowing the cause. Is it advisable for the patient to go into IVF, and what tests is expected to be done by the person?
Only having one miscarriage, even not knowing the cause, the recommendation is try again a new pregnancy, because most of the times you will not need to perform a fertility treatment, an embryo selection with genetic testing. This is only statistics, but on the other hand, if you perform fertility treatments to all the people having one miscarriage, maybe you are over-treating people that will never need, most of them will never need an intervention or treatment. So my recommendation, only having one miscarriage is very common in the human race. We have a lot of miscarriages, and it's predicted that after having one miscarriage, 80% of the times in the second pregnancy, you will not suffer a miscarriage. This is only statistics, but because medicine is not an exact science, it's not mathematics, it's not physics, we tell always about the statistics. This means what to expect in similar cases. In similar cases, most of the women with no intervention get pregnant and have a child in the end. Okay.
Brilliant. Thank you so much indeed for that advice here. In the meantime, we did receive one more question. Let's have a look. Is it better to have medical management of miscarriage as opposed to D&C surgery? Are there risks with scarring in the lining?
Very good question as well. So it depends. Today we offer the patient to consider medical management because it has no intervention. It's a very clean way to remove the miscarriage from the uterus. But sometimes it's not easy. The medical management is not working, and you end offering surgical intervention. We prefer medical management in the first line, but it depends on the patient. Some patients are telling you, "Oh, doctor, I prefer to finish this as soon as possible. Please, I will go to surgery room, sedation, and then I leave the clinic in a couple of hours, and I will not be waiting for if I am able to remove by myself this miscarriage." But the best option is being with the medical intervention in the first line of treatment of these miscarriages. And sometimes very few risk with affecting the lining because of the curettage. But you can see in the informed consent always telling about the risk of adherences because of the curettage, etc. There are very few cases, so don't be afraid to the surgery removal of the miscarriage, but the best option is considering at first the medical management.
All right. Again, thank you so much for your question and for the clarification. And as you can see, that was for sure helpful. There's a comment here from Victoria. Thanks so much.
It's been a pleasure, Victoria, for all of you. Thank you.
Thank you, everyone, indeed, for joining us tonight. I hope that was, very useful for you. And remember, this is not our last webinar with Dr. Izquierdo. He will be back here in 2 weeks' time. So I hope you will be able to join us, and we will discuss some other topics as well. As you know, we will be back here also in the next few weeks. So you can join us and ask your questions. And tonight, that will be it. But Dr. Izquierdo, thank you so much indeed for joining us tonight. I'm glad that you were able to be here. And I know that you have some more webinars with us. So I'm already looking forward to it. Thank you for your experience. And of course, I hope to see you soon, right?
It's been a pleasure, and we see each other in a couple of weeks.
Definitely. Thank you so much indeed. Have a lovely evening, everyone. And of course, as you know, you can find us on My IVF Answers. And if you go to our YouTube channel, you will find all of our previous webinars. There are plenty of those, so don't hesitate. Thank you so much. Have a good day. Bye.
Bye-bye.